Now, why do we do blood gases? I think blood gases are awesome, awesome investigations. I think they're fantastic in helping us diagnose, manage, and even monitor patients and their treatments. Can anybody, whether arterial or venous, can anybody suggest any reasons why you might do certain blood gases? So let's talk about arterial. What are some of the indications for an arterial blood gas? Respiratory distress. Immediate answers without waiting for labs. Yep. Can you expand on that? Any particular scenarios? Sepsis, no doubt. Any others? Looking for potassium or lactate? Yeah. Yeah, so it does give us some immediate answers, really. And a venous blood gas can also do the same. You may even want to use it to monitor. So for example, in patients, well, we'll come across certain scenarios anyway, but in certain patient groups, a blood gas is very, very useful when it comes to monitoring them, and can be of great assistance in doing so. So the various different components of a arterial or venous blood gas, it's important to understand what they are and what they tell us. The first thing is the pH, which ultimately tells us the acid-base status. Broadly speaking, a low pH is acidotic, and also a high pH is alkalotic. Normally, pH ranges are between 7.35 and 7.45. The next important parameter is PCO2, which is normally between 4.7 and 6. And that tells us what the respiratory function is like. So for example, elevated PCO2 normally tells us that there must be a problem with breathing, whereby the patient is retaining CO2, which is, of course, contrary to what it should be doing. And therefore, this can suggest some form of pathology. And CO2 is always paired with O2. The body is designed to take in O2, so oxygen levels should be high. So partial pressure of oxygen gives us an indication of oxygenation. Venous oxygen is almost always lower than arterial. I mean, it is always lower than arterial because, of course, venous blood contains less oxygen. But in arterial situations, if there's poor oxygenation, then of course the level of oxygen will be considerably lower. And you've got your electrolytes. So important electrolytes include sodium and potassium, calcium, and also chloride. If you're not thinking it, you won't look for it. So you have to be thinking of it. When you're given a blood gas, please look at electrolyte states. Common indications for blood gases, especially venous, include abdominal pain, include, for example, shortness of breath. But with abdominal pain, that pain could be due to a pseudo obstruction, as an example, as a result of low potassium levels. Glucose, underrated, but so useful, especially in some instances. Can anybody think of particular circumstances in which knowing the glucose is really important there and then? DKA, yep. Think about a patient who's had a fit, who's had an epileptic seizure. It's important that we know about what their blood glucose is like. And lastly, lactate. Lactate is also really important. Well, not lastly, actually, we've got a few more, but lactate is also important because it can indicate tissue hypoxia. Situations like sepsis metabolic disturbances, and ischemia are important reasons why lactate could be raised. There are some other important things I would say. Hemoglobin can be often forgotten that hemoglobin levels are also found in blood gases. Arterial or venous blood gases, especially in a point of care scenario, can help us make rapid decisions. So for example, if there is a patient that has heavy menstrual bleeding and is going through lots of pads, passing clots, etc., we need to decide whether they can go straight up to see gynecology to have them condition managed, or whether they need to be stabilized first in emergency medicine or the emergency department. So a hemoglobin point of care tells us what their hemoglobin is like, and therefore we can make that onward referral quicker and allow for better patient flow as well as maintaining safety. Oxygen saturations always help me and confirm whether a patient has had an arterial blood gas or venous blood gas. A low saturation normally tells us that, a low saturation in a normal patient normally tells us that it is a venous blood gas, whilst in a patient who is unwell, a lower saturation needs to be read with the clinical circumstance. And then we've also got base excess and bicarb. Bicarb is really important because bicarb tells us the metabolic status of a patient, particularly when it comes to rather compensation. So I know that's a lot from a venous blood gas point of view. From a blood gas point of view. I want to spend a little bit of time talking about venous blood gases and just a few cases before we go for our break. So I think venous blood gases are really important. I don't know how you guys feel about them, but I feel they're so useful. They're easy to do because you can just do them whilst drawing blood. They run in a matter of minutes and they give you so much information. They're also really good for the patient because it means that you don't need to prick the patient twice or even obtain a painful sample from an artery. However, in some cases, it's really important to get the atrial blood gas instead of a venous blood gas. Can anybody recommend some circumstances where a VBG just doesn't do the job and you have to get an ABG?
Good morning.
Hello, are you free or should I try again in a bit?
No, it's fine, absolutely fine. I was just sitting on the dining table, drinking a cup of tea that my son had made.
All right, that's good.
Without asking. Hello, what the shop?
So what kind of circumstances we have to get an ABG?
Yeah,
so I would say definitely in patients who have respiratory problems. So respiratory acidosis, respiratory alkalosis. If you're thinking of respiratory pause, for example, a COPD exacerbation or an asthma exacerbation, venous blood gas doesn't do. So here's our first case. So John Doe, classic, 58-year-old,
delicious.
CPD, stage 4, hypertension, type 2 diabetes.
Oh.
I didn't make it. Current medications
much for Polish.
includes lisinopril, 10 milligrams daily, metformin 500 milligrams twice daily. Can everybody hear me?
I'm a little bit sad to leave Polish behind because that's double. I found Greek.
Turns out that I can't hear much. Oh yeah, okay. Right, so yes, so back to John Doe. So chronic kidney disease, stage 4, hypertension, type 2 diabetes, lisinopril 10 milligrams, and metformin 500 milligrams twice daily. And here is a little bit of a description as to what's going on. So have a read of the actual presentation. So just a little bit more information for you guys. So now we've got an examination, by the way. So on physical examination, this patient is mildly distressed, appears a little bit tired and fatigued. These are the vital signs. So blood pressure is 155/92. Heart rate is 108 beats per minute. Slightly tachycardic. Respiratory rate is 18 breaths per minute. Temperature is 37.0, whilst oxygen saturation is 95% on room air. You've examined them further. So the tachycardic, regular rhythm, respiratory exam is clear, musculoskeletal exam is just mild muscle tenderness, and abdomen is soft and tender. And you decide to do a venous blood gas. So you find that the pH is slightly acidic. The CO2, I think that's wrong, to be honest. 34 mmHg. I think that requires some correction. Anyway, the bicarb is 19 and the lactate is 1.1 millimoles per liter. Oxygen saturations are 75%, of course, it's a venous sample, but you find that they have a potassium of 6.7. So this is hyperkalemia. In terms of interpretation, just some important things. So as you can see, the potassium is 6.7. Hyperkalemia is almost always associated with acidosis, right? So this is it's always got some semblance of metabolic acidosis. Whilst hypokalemia normally is associated with alkalosis. So this is metabolic acidosis secondary to hyperkalemia. Hyperkalemia is the obvious finding really here. And of course, is the cause in this instance an AKI? Who knows? In other words, you still need to do an ECG, IV calcium gluconate, IV sodium bicarbonate, or even insulin plus glucose to lower the potassium levels. Now, these patients will require repeated venous blood gases because the time it takes for labs to come back, it just doesn't allow you to act in the time that's necessary. So VBGs are really useful for the monitoring of patients, and that's what I meant when I used that term. Let's move on to the next case. Sarah Miller, this time, who's 43 years old with a background of hypertension, peptic ulcer disease, recently started on NSAIDs. These are her current medications. And this is her case history. So she presents to the emergency department with acute, severe abdominal pain, nausea and vomiting for the past 12 hours. Pain started suddenly and is described as sharp, crampy, and localized to the upper abdomen, radiating to the back. She reports a loss of appetite and feels generally unwell. She has not had a bowel movement in the last 24 hours and has been feeling increasingly weak. So it sounds like this lady is quite unwell, actually. On examination, she's distressed, she's pale, and her vitals show that she's got a low blood pressure, a high heart rate, a low-grade fever, and also oxygen saturations of 97, which is fine. But when you examine her, you find that she's very tender in the epigastric region with guarding and rebound tenderness. Her bowel sounds are pretty diminished, and cardiovascular system, she's tachycardic, regular rhythm with no murmurs, and she is clear to auscultation bilaterally. You decide to do a VBG. Of course, you're going to be in reality doing lots more investigations than just a VBG, but let's just say for argument's sake, you're just going to do a VBG for now. Does anybody know what the diagnosis could be, by the way, based on this information already? Perforated ulcer? Could be, yeah. Could be a perforated ulcer. Anything else that might cause epigastric pain that's really bad with low blood pressures? Pancreatitis, yeah, I would agree. That's also a strong differential here. So on a blood gas, you obtain this. So you've got a pH of 7.28, CO2 of partial pressure. Oh, it should be 3.5, I think. I'm not sure why it's coming up in MMHG. That's fine. So partial pressure of CO2 of, so pH of 7.28, and bicarb of 16, which is low. So she's got a acidotic pH and a low metabolic, and a low bicarb, but she's got a raised CO2. So we'll just go with the description, raised CO2. So she's trying to compensate. But lactate is 6.8. So if you had this patient and you were in secondary care, for example, what other investigations would you do? Or what would you think about doing for this patient? Yeah, a CT abdomen. So an abdominal CT scan is really, really important. The elevated lactate here strongly tells us that there's some form of tissue hypoxia because of inadequate blood flow to the bowel. Could be because of mesenteric ischemia. Could be because of, for example, could be because of a perforated DU. Could be because of pancreatitis. All of these instances can cause the pH to drop, can cause this abdominal pain, can cause these patients to be that unwell, for example. I would probably say that so what would probably, so some risk factors, of course, in the history you would need to include if the patient's been taking some NSAIDs, which points to a particular diagnosis like duodenal ulcer perforation, or gastric ulcer perforation, or if the patient has a background of AF, which would tell us that it might be mesenteric ischemia. The low pH indicates metabolic acidosis, which of course is common and other in these conditions. And the elevated lactate serves as a real red flag for progress of the disease. So moving on to the last case before our break, because I know we've been going on for some time. Venous blood gas number 3. Mark Johnson, 28-year-old chap, type 1 diabetes, diagnosed at 14 years old, but is non-compliant with his insulin therapy. I think you guys know where I'm going with this one already. No other significant medical illnesses. Current medications include insulin, over-the-counter medications for coughs and cold. Now, when you take a further history, he presents with worsening thirst, polyuria, nausea and vomiting, abdominal pain for the past 48 hours and feeling quite weak and quite dizzy. Has not been able to take his insulin for the past several days because of nausea and vomiting. His symptoms have progressively worsened over the last 2 days, and he's feeling really tired and really confused. And his family noticed his breathing has become quite deep and it's become quite rapid. This is a really typical circumstance, by the way. Have you guys seen patients with such a presentation before? On general appearance, he's alert, but he's slightly confused and he's dehydrated. Vitals show that the blood pressure is hypotensive, heart rate is raised, respiratory rate is 24, and the temperature is 37.1. You find him to be quite tachycardic on examination. He's having deep and rapid breathing, which is known as Cosmo respirations, and of course, mild tenderness in the epigastric area. He's confused, but he responds appropriately, but appears lethargic. You do his blood gas, and you find the following. His pH is 7.22, which is low, indicating acidosis. PCO2 we can disregard because it's a venous blood gas. Bicarb is low. So, you know, that supports the fact that he's quite acidotic. So the bicarb is trying to eat up all of the acidic ions in the blood to try and balance the pH again. Lactate is raised, most likely because of dehydration here. And of course, glucose is through the roof. This patient has a typical presentation of DKA. DKA is a state that's marked by hyperglycemic metabolic acidosis. These patients are severely dehydrated, and often they either present as a first presentation of type 1 diabetes, especially in a child, or when patients are non-compliant with their medication. Very rarely it's due to a really bad infection, because insulin nurses and diabetic nurses are incredibly great at providing detailed advice concerning concerning what to do with your insulin if you're unwell. These patients require, well, actually, let me ask yourselves, what if you do find a patient with diabetic ketoacidosis, what kind of treatment do these patients require? What do we need to do? Fluids, yeah. So we need to give them a lot of fluid quite rapidly, and then also give them insulin. The reality is that they will need venous blood gases again and again and again. The reason why is because we need to very carefully manage their potassium levels. If their potassium levels start to get lower, then we need to give them potassium back. Insulin, when given in high amounts, especially in patients with DKA, can reduce the potassium quite considerably, which is why we monitor it. Often what I do is actually I just stick another cannula in. I just put another cannula in. I ask the nurses to not put any fluids in, to not put any medication in through that cannula. It's just an extra. Reason why is because in emergency medicine, because we know that we're going to be taking so many venous blood gases from these patients, instead of pricking them with a needle again and again and again, you can just bleed that one cannula back. This is an exception. Normally, we're not allowed to bleed cannulas back. It's not something that's recommended in UK practice, but however, it can be used as a method in exceptional circumstances, especially in patients with DKA who require repeated blood gases. EPGs and ABGs are both very important. ABGs hurt a lot more. And we know that because we're, of course, injecting a needle into an artery and trying to draw blood from that. Unfortunately, for patients who have COPD, they are having lots of ABGs in regular intervals, and it's an incredibly painful experience for them. Some clinicians like to inject some local anesthetic. Some clinicians like to put some EMLA cream, but most clinicians just like to go straight in there because of the acute nature of doing an ABG. The extra pieces of information that we normally get from an ABG are oxygen and, of course, carbon dioxide levels in the arterial system. There's a really important test that you should do before doing an ABG in any patient. Does anybody know what that is? So before you even do an ABG in a patient, there is something that you really need to check in a patient. Modified Allen's test. Absolutely. Why do we do the Allen's test? What's the reason behind doing the Allen's test? Yeah, because of course we've got the radial artery and we've got the ulnar artery. And for some people, they don't have a dual blood supply to their hand. So if you are to put a needle into, so if they've only got one artery, for example, that supplies the majority of the blood to the hand, and you put a needle into that, yes, you might draw some blood, but if that artery then clots and then subsequently becomes occluded, that patient's hand is going to become very quickly ischemic, and you don't want really that to happen. The BTS recommends routine use of local anesthetics for obtaining ABG samples. The majority of the time when you do an ABG, you are doing it urgently. The indication is pretty urgent, and therefore very few people have the time to use local anesthetic in that scenario. Now, respiratory failure is probably the most common reason why we do ABGs. So there are two types of respiratory failure. There's type 1 respiratory failure, and there's, of course, type 2 respiratory failure. In type 1 respiratory failure, you have hypoxia or hypoxemia, but with normal capnia, so normal PaCO2. Normally, this is as a result of a ventilation-perfusion mismatch. In other words, the volume of oxygen that's flowing in is not necessarily matched with the flow of blood to the lung parenchyma. Practically speaking, this could be as a result of a reduction in the blood flow to the lungs. So, for instance, in instances of pulmonary embolism, where there is a clot and therefore there's a reduction of blood, so therefore the body's oxygen carrying capacity is reduced, resulting in hypoxemia. Or it could be in instances like asthma, where there is significant occlusion and inflammation of the small bronchioles, and subsequently that reduces the amount of oxygen flow into the lungs themselves. Type 2 respiratory failure is slightly different. This is when you have hypoxemia with hypercapnia, so a low PaCO2 with, or a low PO2 with a high PaCO2. Typically because of problems with hypoventilation, resulting in patients being unable to remove CO2 from their blood and resulting in high levels of CO2. The most common example of this, of course, is COPD, but also neuromuscular conditions such as motor neuron disease, Guillain-Barré, and others, because they reduce the amount of the volume and also the quality of respiration. CO2 starts to collect and patients can have type 2 respiratory failure. The first step with ABGs, like with any blood gas, is always to look at the pH. And we have a separate masterclass for ABG interpretation where we go through things in a lot more detail. But of course, here we're looking at the main point of care testing uses of arterial blood gases. We typically look at CO2 and also bicarb to determine the cause of the pH derangement. And there are some important interpreting principles that I'm going to talk about today to hopefully try and bring ABGs together. Now, if the CO2 is causing the pH abnormality, it is what we call respiratory cause. In other words, if you find that the patient has a low pH, but also has a high CO2, then it's likely that this is respiratory acidosis, or vice versa if it's respiratory alkalosis. However, if there is, for example, the CO2 is relatively normal, but the bicarb is, let's just say, for instance, it's low and the pH is acidotic, then it is a metabolic cause. So if it's CO2 related, in other words, if the CO2 is high or low, then it's respiratory, whilst if it's bicarb related, it's metabolic. The way ABGs work and the way the acid-base system works is that wherever the problem is, in other words, if it's a metabolic problem, so to give you guys an example, if a patient has sepsis and the patient has a very high lactate, that means there's excess acid, so they could have an acidotic pH, then what you would find is that you would find some form, and on that blood gas, you because of the acidotic pH, there's low bicarb, you would find the patient breathing a little bit faster to try and offload some of that CO2 in order to try and stabilize the pH. So wherever the abnormality is, if it's metabolic, then the lungs try to compensate, and if it's respiratory, then the metabolic system, the kidneys, try to compensate. So I've got a few patterns of disease here, and this is just a little bit of a quiz. If you get it right, you get it right. If you don't worry about it. But these are some common patterns of ABG abnormalities, and we'll try and kind of go through some of these. So if the pH is low and the CO2 is high and the bicarbonate is normal, how would we interpret this? Yes, respiratory acidosis indeed. Respiratory acidosis indeed. That's correct. So this is respiratory acidosis. Whilst if you have a high pH, and you have a low CO2, and you have a normal bicarb, on the opposite side, what would this be? This would be respiratory alkalosis. Now this is absolutely, Adriana, fantastic. So this is where things get a little bit more complicated. So for example, now you've got a low or normal pH, but you've got, for example, a high CO2, but now a high bicarb. No problems, Jim. Take care. Nice to have you. Have a good day, mate. So if you have a low or normal pH, you've got a high CO2 and you've got a high bicarb. Respiratory acidosis with metabolic compensation. Fantastic. Okay. So it looks like you guys are very, very good with interpreting these. And if you're not, and if it's not what you do in primary care, then not a problem at all. So we're going to run through this. Now, a high or normal pH with a low CO2 and a low bicarb, what would that be? That's a respiratory alkalosis with metabolic compensation. So I'll go to the next one. Low pH with a normal CO2, but a low HCO3 would give you metabolic acidosis, no doubt. And a high pH with a normal CO2 with a high bicarb is metabolic alkalosis. And in a similar way, a low pH, but with, of course, a low CO2 and a low bicarb is metabolic acidosis with respiratory compensation, whilst everything being high would be a metabolic alkalosis and respiratory compensation. So a table that kind of brings them all together really is an example of respiratory acidosis would be, for example, asthma. Patients who have asthma can be breathing very, very fast. There comes a point where the quality of their respiration gets really poor and their CO2 starts to increase slowly but surely. These patients are at a very, very life-threatening stage and they require immediate intervention. Overuse of substances like amphetamines and opioids can also cause respiratory acidosis, but for different reasons. When a patient has taken opioids, their respiratory rate goes down, their CO2 goes up, and subsequently they get acidotic. And of course, COPD. Pneumonia is also another cause of respiratory acidosis, which makes sense. If your lungs are clogged up with lots of stuff, lots of gunk, then of course there's going to be less oxygen reaching those alveoli and subsequently more carbon dioxide collecting because it can't actually cross the barrier, so therefore acidosis. Respiratory alkalosis, typically in patients who are, hyperventilating, patients who have a panic attack or an anxiety attack. Metabolic acidosis is normally found in patients who are diabetic with diabetic ketoacidosis. We had a case earlier in the VBG section that showed that. But probably after that, I would say patients with sepsis resulting in lactic acidosis and also patients with kidney disease. As we said, there is an intricate link between potassium and acidosis. So patients with hyperkalemia can also have metabolic acidosis. And then lastly, we have metabolic alkalosis. And this is typically caused by medication like antacids, diuretics. Other medication include dehydration, GI losses, and also vomiting. The reason why we say GI losses is because the patient may lose their potassium with diarrhea and therefore subsequently have significant metabolic alkalosis. So bringing it all together, the first thing is to always check for their clinical presentation, past medical history, and their oxygen requirement. If they are hypoxemic, we should always try to replace their oxygen first and foremost. So give them an oxygen supplement straight away. There used to be a thing whereby clinicians will try to reduce or limit the amount of oxygen they give to COPD patients on initial presentation, but actually treat hypoxia first and then titrate. The next step would be to look at pH and to decide whether a patient is acidotic or alkalotic. If the pH is normal, but the PaCO2 or bicarb is abnormal, then is there some form of compensation occurring? Then we need to realize that there is a relationship between the carbon dioxide and the pH. Acidosis and high levels of partial pressure of carbon dioxide or alkalosis and low levels of carbon dioxide suggest respiratory acidosis or alkalosis. So if it's CO2 is raised or reduced, it's always going to be respiratory. And similarly, if it's bicarb, so if the bicarb is low and there's acidotic pH, or if the bicarb is high and then there's an alkalotic pH, then this is likely to be metabolic in nature. The last thing, or the last concept, is compensation. Compensation is only true if the pH is normal. If the pH is acidotic or alkalotic, full compensation has not occurred. Some clinicians like to use the term partial compensation or no compensation. Really and truly, it depends. I tend to just use compensation because until the pH is not fixed, then the problem is not fixed. So just a few examples. Well, one example really. So a 78-year-old frail gentleman presents to A&E breathless and drowsy. How can we describe this ABG? Metabolic. So we say metabolic acidosis. No, people are still typing. So I would look at this ABG and I could clearly see that the pH is low. So there is some form of acidosis. The oxygen is also low. Oh, right. Okay. I can see the answers now. Respiratory acidosis with partial metabolic compensation. Yeah, I agree. So we can see that the pH level is low, which indicates acidosis. The oxygen level is also slightly low, which indicates hypoxia. And of course, we've got significantly raised CO2 levels, which is hypercapnia, and the bicarb is also elevated. So this is partially compensated respiratory acidosis occurring in type 2 respiratory failure. And the situation most likely representing this is COPD exacerbation. Now, ABGs are really hard. They're not easy at all when it comes to interpretation. And I would implore you all to think about purchasing our ABG ebook. It's only $4.99. It's yours to keep, and it goes through the most fundamental aspects of arterial blood gas interpretation. It's also got practice cases with full explanations as well. So if you are interested, you can always purchase those on our website.